Good day, friends, and a warm welcome to episode 6 of season 2 of 4D Detailed Discussion and Dialogue in Diabetes. Detailed Discussion and Dialogue in Indian Diabetes. In this journey in which we are together, we work to learn more about diabetes in India and how we can manage the unique challenges that we face in practice every day. Today, we have an expert from Chennai, somebody who is good not only at clinical practice but also at public health and advocacy, someone who is known for his oratorial skills. A warm welcome to Dr. Pradeep KS, Dr. Pradeep Shekhar. Dr. Shekhar is medical director and consultant diabetologist at the B Wells Hospital in Chennai. He is also managing director of DiaCheck Clinic in Chennai, and he has worked earlier at New Hope Family Care in the same city. Warm welcome, Dr. Pradeep.
Thank you, Dr. Sanjay.
Dr. Pradeep, we
Um,
are
we-
told, we are told about the seasons in Chennai. Hot, hotter, hottest. What
yeah, it
is
just
happening in
started
the
like a month back. Hot,
yeah,
hot just started. So we'll go into hotter by February, and by March it will
March
be hottest.
hottest? So, what
Yeah.
happens in the diabetes clinic? You've have so much of experience now. Is it becoming hot, hotter, hottest in diabetes? What is happening?
It is become younger and youngest actually.
That's true. We are getting them
So
earlier.
you see more and more younger people getting diabetes, and now now getting 3 to 4 generations of positive diabetic history, which is not there at least 20 years back, right? So awareness is much more started much earlier in this part of the world, and so now you have 3 generations of diabetes, and the fourth generation has a strong history of diabetes. So they'll get it
And
somehow in the future. So the challenge is not only to actually treat the diabetes; it also is to make sure that the onset of diabetes is delayed for the next generation.
and what is happening to body weight, to body mass index? Is that going the opposite direction? Heaviest?
Yeah, see, overall in Indians per se, the BMI, when you compare it with the Western population, the Caucasian population is much lower, but our muscle mass is already very low. So what we find is that even with a marginally higher BMI of just overweight category, we fall prey to all the diseases of non-communicable diseases of diabetes, hypertension, and the dyslipidemia, and the complications of CVD, especially in the South Asian population, is very high. And then microvascular complications, if the sugars and BPs are uncontrolled, then you have kidney eye problems as such. So uh, overall in weight, even marginal 24 25 BMI is actually not healthy. But at the same time, even if you have a 23 24 BMI with a big tummy, so if your adipose tissue is concentrated around the abdomen region with considerable visceral fat, then you are again at risk of getting diabetes. And as once you go up the economic ladder, stress also becomes a important part in our life. Our jobs are getting much more stressful, even for doctors, and that adds to all our problems. Now you have more awareness of the psychological stress that one receives in one's lifetime. Before, it was always categorized as being mental. Now almost everyone knows that at least in one part of their life they do undergo this stress, and no one is immune to it. So in that way, that also adds to the burden. And you can see actually people who having perfect control for years, suddenly you find their HbA1c all over the place. When you ask a little more deeper, you find that it's nothing but just a family problem that is going on, never faced that in their life before. Suddenly their sugars are all over the place.
That's true. So you mentioned about obesity, also normal weight obesity and diabetes. And then you mentioned that these people are more prone to cardiovascular disease. So this is the unholy trinity:
Yeah.
diabetes, obesity, and CV disease. And many people say that, of course, it's difficult to decide what comes first, the chicken or the egg. But many people say it's obesity that's the root problem. So would you like to speak more about this, sir? And the floor is
I
yours.
think has been spoken in detail in our landmark studies, right? So the Wikipedia's and all those studies gave a clear indication that microvascular and high sugars, that legacy effect and all those things, they had much stronger correlation. Whereas even getting sugars under control, although did help in their cardiovascular outcomes, but not that great a deal. And since so they concluded that cardiovascular outcomes is more in tune to not only diabetes but other, even IGT now is actually a risk factor into cardiovascular outcomes. Insulin resistance is a big factor. If you take insulin resistant, that you find that almost 80-90% of Indian population will fall under the higher risk category, because insulin resistance is omnipresent. Whether you have diabetes or not is only a question. Insulin resistance is definitely there in everyone. It is there in me and you also. So when you go into that category, we found out that even having IGT, even before diabetes, you are already at risk of cardiovascular diseases. And we find that I am not able to pinpoint where exactly we are losing this battle, but South Asians, even in America and UK, they have actually a higher predisposition to a cardiovascular disease. Not only in India, but even the South Asian population in the amongst the expats as well, they also have a higher predisposition. And we need to come to the exact root of what is it that causes our hearts to actually blood vessels getting clogged
Real
up.
faster, yes. But we look forward to your presentation, sir, and we are waiting to listen to you in more detail.
We're looking at body weight and how it is a risk factors for diabetes and cardiovascular disease. So, obesity in India is a very complex condition, and it is more of the visceral adiposity that actually kills us than subcutaneous adiposity. And it is also associated with adipose dysfunction and insulin resistance, which increases the risk of diabetes and CVD. And in urban India, almost 3 out of 4 Indians are overweight, and prevalence of abdominal obesity was found to be 40% women and 12% in men. I think if you update that study, it will be much more in urban India rather than in rural India. And studies show that 5 to 6 out of 10 women between the ages of 30 to 49 are abdominally obese. The association of abdominal obesity in women is stronger with older age groups, urban residents, wealthier sections, and non vegetarians. Indians are known to have the highest cardiovascular diseases, or CADs. The prevalence is almost 21% in India, and 11% for diabetes, and for 11% for non-diabetes. And prevalence of CAD in rural parts is nearly half that of the in the urban population. So we all know of the prevalence of diabetes in India. It's almost 9% in the adult population, and if you see the hidden diabetes, the ones that are undiagnosed, we find that that will be another 3 to 4% easily. The numbers which are not available, and nearly 25 million, quite a sizable number of population are pre-diabetics, so at the risk of developing diabetes in near future. And we have studies comparing pre-diabetes in India, China, Korea, and all those other population. We find that people in India who are pre-diabetic become diabetic on a much faster rate than the other population. So this is a study which links the relationship among diabetes, obesity, cardiovascular disease. It's a UK-based cohort study, and basically they took people from into two groups. One is the non-diabetic, the other was the diabetic, and they found that what is the risk in the population with normal BMI, more overweight BMI, and the obese BMI. Same with the diabetes as well, and found out that what is the incident ratio and the intervals for cardiovascular death in each of these BMI categories. And they found that if you are a diabetic and obese, you are very high risk incident rate of cardiovascular death, that you're more likely to get a cardiovascular disease and followed by death. And as this goes across the spectrum. So if you're normal in BMI and you are non-diabetic, then there is literally the incident rate ratio is similar to a uh, much lesser than compared to a diabetes and overweight. Next. So, what is the mechanism? What is the pathophysiology behind it? So, all know adipose tissue releases FFAs, free fatty acids. It also releases adipokines, which causes inflammation, and then which decreases protein quantity and quality by causing a defect in the translation pathway. Inflammation also leads to insulin resistance, which again leads to diabetes, and free fatty acid then causes impaired oxidative capacities, which then leads to accumulation of lipid derivatives, followed by lipotoxicity, and then defect in translation pathway. So eventually, you have mitochondrial dysfunction in diabetes that also causes oxidative impaired capacities, aggravating factors like excess lipid intake, inactivity, immobilization, aging, chronic disease. All these again increase the impaired oxidative capacity, leading to accumulation of lipid derivatives. So eventually, all these things cause accelerated atherosclerosis and then leading into cardiovascular disease. So, how does insulin resistance simultaneously cause diabetes and CVD? We'll see in this slide. As you can see, insulin resistance leads to more insulin production because the body needs to bring down the glucose, so that so it has to take care of the insulin resistance as well by secreting more insulin. That actually causes increased MAP kinase activation, which leads to accelerated atherosclerosis. Whereas insulin resistance causes impaired PI3 kinase signaling, which leads to impaired muscle glucose uptake and impaired suppression of glucose production, which leads to type 2 DM eventually. So, how do we prevent it? So, obesity, we all know how to prevent it. We need to limit unhealthy food. We need to personally do it. Awareness is being created nowadays through social media as well by a lot of doctors and nutritionists on what to eat, how to eat, what are the different types of diets available, etc. But eventually, on the ground, for us to do it and for us to advise our patients, that is one more thing, and to make sure that our patients follow it and the general public follow it in large, that is a big a challenge that we need to address. We make sure that we are healthy, and make sure that we don't succumb to the uh, uh, normal habits that actually spoil our life and lifestyle. So we need to increase our physical activity as well. We need to limit screen time and all those things. We need to improve the sleep and reduce the stress. Type 2 DM, we need to have a proper BMI. We need to stay physically active with at least 30 minutes of moderate exercise each day. We need to eat a healthy diet. We need to completely avoid refined sugars in all its forms, and we need to reduce saturated fat as well. Smoking and alcohol, best avoided. If we can't avoid, then very rarely is the motto. For cardiovascular diseases, don't need to emphasize more on the diet and activity. We all know that smoking is a direct risk factor for cardiovascular disease. So definitely no smoking. We have to keep our blood pressure, lipids, and sugar under control. So, what are the therapeutic strategies into managing weight? So, FDA approved medications that we commonly use in India are liraglutide and semaglutide. Semaglutide is now available in an oral format. Injectable is not yet released. Liraglutide has been there for quite some time. These are the long-term use. The disadvantages with them is they do bring down weight a little bit, at least 5% to 10% in some cases. The higher the weight you have, the higher the reduction, but we have to understand that it does have a ceiling. You cannot keep reducing weight by increasing the time duration of taking this medication. We definitely need to supplement it with diet and physical therapies. Alone, no anti weight drug is going to work. Whereas in anti hyperglycemic agents, we have so much going on, and but in the newer medications, we have DP4 inhibitors, SGL2 inhibitors, and GLP-1 analogs. So this is about heart failure and reduced ejection fraction, and uh, the AHA, ACC, all these guidelines they actually target um, empagliflozin and dapagliflozin once daily for these patients. So they found out that along with SGL2 inhibitor having effects on the kidney, it also has a favorable effect on heart failure as well, and managing heart failure as well. So it is recommended to use these drugs in heart failure patients. So patient with diabetes and heart failure, some cardiologists even without diabetes they do use dapagliflozin and empagliflozin for their heart failure patients as well. So this is a study, a 24-week international multi-center randomized double-blind study, which basically sees the primary endpoint is to see the HbA1c and fasting plasma glucose after effective dapagliflozin, and we found that a lot of patients achieved a therapeutic glycemic response, and also body weight and SBP were reduced from baseline over a 24 and 8 week respectively with the dapagliflozin, and it was significantly lower than compared with the placebo. So what happens when we combine an SGLT inhibitor with a DPP4 inhibitor? So SGLT inhibitors are fairly new, whereas DPP4 inhibitors are there for more than a decade now. And the best thing is that they both don't overlap each other in their function. DPP4 inhibitor is more concentrated on the gut, pancreas, whereas SGL2 inhibitor acts mostly on the kidneys. And when you combine them, the both, you actually get a additive benefit rather than actually an overlap in benefit. So if one gives 0.8% reduction, the other gives 0.7% reduction, when we combine both together, HbA1c reduction is easily more than 1.5. So we all know how SGL2 and DPP4 inhibitors work. When we actually combine both, we improve both insulin resistance and functioning of beta cells. It is safe, rapid, and sustained glycemic control since it doesn't act on the beta cells to increase insulin secretion. It doesn't have a shelf life. You can use it throughout your diabetic journey, and it will have a similar sustained effect on your glycemic control. It both of them are body weight positive, so it decreases body weight, and there is a BP reduction as well. So both these things make sure that the patient are compliant to the drug. By combining them both, we also reduce pill burden a little bit. It is also cost effective, as most companies don't double up the rate. When you combine the both, more or less it will be a positive benefit on the patient's finances as well.
Thank you, Dr. Pradeep. Thank you so much. You've talked about this unholy trinity: diabetes, obesity, and cardiovascular disease. And then you've talked about how we can use a single FDC to manage all these three, to keep them at bay. Let's talk in a positive manner now. We have comments coming from the audience, and three aspects of the holy trinity, not unholy anymore, holy trinity. So, see the words that come across: physio friendly, psycho friendly, and practice friendly or praxis friendly. So let's do these one by one. DAPA CETA combination, sir, given alone or maybe along with metformin, is this physio friendly?
Yes, definitely. Since they do not cause any overall reduction in beta cell or their insulin reserve, they are actually over course of the disease. They do not actually aggravate the disease process as such when compared to a sulfonylurea, which actually squeezes out more insulin from the pancreas. So in a way, it actually depletes your beta cell reserve. So in this, there is actually a positive benefit on that. By reducing weight, we also have to understand that for each kilogram of body weight reduced or fat that is reduced, we have a positive effect on the HbA1c, on the sugar levels, and on the overall comorbidities as well. So that is a significant part. See, BP reduction, although marginal, will always be beneficial for any patient who is diabetic. We all know that diabetes and blood pressure are just first cousins, and both of them, if one has one, the other will is going to come soon. So, in all those aspects, it is definitely physio friendly.
And the other things are that this DAPA CETA combination, it helps in insulin resistance, also in insulin secretion, though in an indirect and patient friendly manner. Even within the islet of Langerhans, it helps the beta cell. It tells the beta cell only when we need you, then you secrete insulin. That is postprandial. Otherwise, you sit back and relax. And the alpha cell also gets de-stressed because sitagliptin de-stresses the alpha cell by improving glucagon sensitivity, alpha cell sensitivity, and DAPA acts as a backup. Supposing there is hypoglycemia, the dapagliflozin will make sure that more glucagon is secreted.
Yeah.
So first was physio-friendly. Then Dr. Pradeep, we noticed from your talk, so many times you've alluded to mental health, to patient satisfaction, patient compliance. What this tells us is that you are a very grounded, patient-centered kind of a doctor. So what does psycho-friendly mean to you? How can we be more psycho-friendly in our clinics?
No, it is pill burden is actually a big elephant in the room. We don't actually talk about it. So I make sure I make it a point to actually make sure that the prescription by length is always as minimal as possible. So if there is a chance to actually combine two molecules and make it into a single pill, that is beneficial for the patient by leaps and bounds. And when on that you add a financial benefit also to it, then patient is always going to be happy. Compliance will is a very key part of our practice as a consultant diabetologist. The first 1.5 minutes of my consultation goes in just to understand whether my patient has taken the medicine that I have prescribed before. So that is very important. So unless we know that what you have given has been taken or not, we are never going to move forward in the consultation. Right. So patient, we can enumerate a number of things that we need the patient to do. If the patient is not going to do it, then it ends there itself. The nothing, whatever you have done is a total waste. So other than so it is very important that compliance is good with the patient, and a prescription which has much lesser number of tablets is always gives the patient a better feeling among himself for or
Certainly.
herself. Yes.
Yeah, you're right. And this is known as the law of therapeutic parsimony. So, as long as therapeutic outcomes or therapeutic aims, targets are met, we should be as parsimonious as well in number of tablets, also in cost of tablets. Dr. Pradeep, this question from audience: do you see very frequently that patient comes and tells you, "Sir, your medicines are hot. They are causing heat in me, or maybe they are causing a headache in me." And actually, what the patient is trying to tell you is that they are causing wallet burn. It's not heartburn or heat headache. It is the wallet is getting heated up. So they are softly, without losing face, they want to tell you to reduce the cost.
uh, my patients are not so generous. They are openly saying that, sir, your tablets are very costly, you do something about it.
Okay.
Or nowadays they're much more open, sir, can I get it through this central government's pharmacy?
Mm.
So that is also there. So patients are much more open about it. I probably because my practice, I ask them these direct questions. So whether they are comfortable with their monthly. So we have to understand one thing. This is like their grocery bill. See,
Yeah.
diabetes, hypertension, cardiovascular diseases, once it is set in, more or less reversal is very difficult. It requires a lot of willpower from the patient as well. But more or less 99 out of 100 cases, it is going to be there for life. So it is like their grocery bill. Every month they are going to incur an expense. Some people, they will not be able to afford the expensive drugs that are available in the market. Some people will be able to afford. Some people might not even be able to afford the generic drugs that are available in the market. So we need to be open about it, and wherever we can cut costs, we need to go ahead and do it, so the patients not only feel better amongst themselves, the patient's wallet is not also depleted at the start of the month by just purchasing these tablets. So in that way, like I said, if you can bring the molecule together, and additionally you can bring the cost lesser also, then it's a win-win for everyone.
So, physio friendly and psycho friendly. We see that when it comes to these two parameters, our FDCs like dapagliflozin, sitagliptin fit the bill. The third is praxis friendly or practice friendly. So, Dr. Pradeep, you run a busy OPD, and everyone who is listening to us now across India, everyone is equally busy. As an Indian physician, we have to manage acute and chronic disease together. So the first patient in your OPD might be chronic diabetes, just coming in for a refill. Sir, what is my cholesterol? Is my SGOT-PT okay or not? And the second one might have a melanoposthitis, a diabetic foot ulcer, might have tuberculosis or community-acquired pneumonia. So you have to keep on juggling within so many things. Uh, what happens to chance of error in the diabetes clinic? It's all doctors listening, all colleagues across the country. And how do we minimize these errors? How can we use praxis
Errors
friendly
in the prescription, or
in our prescription? Yeah, it can be an error in our prescription. It can also be an error in dispensing. The pharmacist has to handle doctors of different specialties. There must be 33 crore types of medicines in the country right now. So how do we minimize errors by using FDCs?
uh, we- lesser the number of tablets itself means that the lesser the chances of error in the dispensing or in the writing as such. Uh, if you if, My personal suggestion is to always have a backup software to actually dispense your medicine, so that the number of error is always lesser and people don't need to actually understand your handwriting. It is always best to have a software, a printed prescription. But other than that, if you have a regular OPD and diabetics are also part of your general practice, and you might get other cases as well, it very rarely a fixed drug combination will actually mimic any other branded molecule, like an antibiotic or
Mm,
antipyretic, analgesic, and anxiolytic, etc. So because they have all the three names together, and more or less you have a dosage at the end, so very clearly write what the dosage is of the molecule. Make sure that you write whether it's before food or after food, and this itself will make sure that you the dispensing problems are not there initially. When we write before food, that itself means that the pharmacists understand that this has something to do with diabetes. Very rarely a general tablet dealing with other diseases have come before food. And when you have a multi-drug combination medicine, when we mention the milligram of each and every drug in the combination, we can definitely avoid any such errors that are actually generating from our prescription. So in that way, it is definitely a prescription friendly drug.
Thank you, Dr. Pradeep. It's been great listening to you. Your
Thank you.
insights, coupled with your practicality, pragmatism, this is what endears you to all of us. And on behalf of everyone who is listening today across the country, I'd like to thank you. But we have
Thank
one last question for you, sir, before we leave. The
thank you.
question
Yeah.
is, which state makes the best sambar? Is it Tamil Nadu or is it Karnataka? And this question comes from a listener in Bangalore.
for for Kannadigas, Karnataka, and for Tamil, it is Tamil Nadu.
So thank you, sir, and to everyone who is logged in. Thank you for being part of 4D, that is detailed discussion and dialogue in Indian diabetes. And we look forward to
Thank you.
being together in this journey towards better health. Thank you, sir,
Thank
and
you.
Jai Hind.